Good evening, respected professor and my dear students. I welcome you all to seventh session of Miot students under the RAISA DNB online academic activities. Today we have four important questions. Time permits, we'll have some asking questions also, as we said, professor. First question will be presented by Dr. Sanjutha from Miot, anesthesia for Hypec surgery. Over to Dr. Sanjutha, please.
Hypec, hyperthermic intraperitoneal chemotherapy, is highly concentrated heated chemotherapy treatment that is delivered directly to the abdomen during surgery. Hypec is usually combined with CRS, that is cytoreductive surgery. It has got effective multimodal treatment option for patients with peritoneal surface malignancy. And also it improves the median survival as well as 5-year survival rate. Any intraperitoneal delivery, it ensures high increased concentration of cytotoxic drugs tumor bearing peritoneum uniformly and keeps the systemic levels drugs low. The chemotherapy can penetrate only up to 5 millimeter. Adequate cytoreductive surgery is required to remove the visible tumor mass. This hyperthermia means there's a temperature of 41 to 43 degrees Celsius is given to there is selective destruction of malignant cells by reversible non-selective inhibition of RNA, and it also causes mitosis arrest in the malignant cells. It also increases the tissue penetration for the drug, causes vascular stasis in the microcirculation of the malignant tumor, and this causes anaerobic glycolysis and acidosis. In the acidotic environment, there is activation of the lysosomal enzymes, which causes accelerated death of the malignant cells. And the heat and the cytotoxicity of the chemotherapeutic agents, they act synergistically so that it is the uptake in the malignant cells. What are the indications for Hypec and CRS? Peritoneal carcinomatosis from the colorectal appendicular gastric tumors, pseudomyxoma peritonei, peritoneal mesothelioma, low volume peritoneal seeding from the gastrointestinal tumors, any perforated gastrointestinal tumors, prophylactic procedure to prevent peritoneal metastatic disease in patients with high risk of developing peritoneal metastasis, and also as a palliation of malignant ascites. Now, what is the selection criteria for Hypec? Medical optimization with no active cardiac condition as per AHA guidelines on perioperative cardiovascular evaluation and care for non-cardiac surgery. There should be absence of extra-abdominal disease and or extensive hepatic mets and significant retroperitoneal disease. Peritoneal disease that is amenable to complete or near complete resection. Before the surgery, there should be preoperatively, there should be a thorough assessment of the pulmonary and the cardiovascular system. Echocardiography and dynamic cardiac assessment is required. Full blood count, coagulation profile, electrolytes, urea and creatinine is required. We have to review the nutritional status of the patient and measure the preoperative albumin level. And this estimation of GFR is required because there is a risk of AKI due to the surgery and also due to the chemotherapeutic agents used. Coming to the surgical technique, the surgical technique is divided into 3 stages. One is exploration. Exploration is midline laparotomy incision and is evaluation. The second stage is cytoreduction or debulking. The surgeon will remove the visible mass or macroscopic tumor, and it also involves organ removal also. And third stage is chemoperfusion. Here the abdominal cavity is rinsed with heated chemotherapeutic solution. And this Hypec is delivered in usually 2 forms. One is open technique or closed technique. Open technique is also known as Colosseum technique. Here there is optimal distribution of heat and cytotoxic solution due to manual stirring of the abdominal contents. But since it is an open technique, there is a disadvantage of heat loss, and also there is a risk of spillage of cytotoxic drugs. So, since there is a disadvantage of heat loss, it requires increase in temperature of peritoneal fluid, so which also has risk of scald injuries. In closed technique, it prevents the heat loss associated with the open technique. It also decreases the drug spillage and it also increases the drug penetration. The duration of the Hypec procedure, that is the installation of chemotherapeutic agents, it varies from 30 minutes up to 2 hours. Next, what are the physiological changes during hypox? We'll go system wise in this. First, in cardiovascular system, there's increase in heart rate, increase in central venous pressure. There's no significant change in blood pressure. In a respiratory system, there might be an increase in peak AV pressure, an increase in end-tidal carbon dioxide, and this decrease in PaO to FiO2 ratio. In renal, it decreases the perfusion to the kidneys. This might result in metabolic acidosis with increase in lactate. Coagulation, there might be decrease in platelet and increase in PT and INR. So coming to the intraoperative management, we have one is fluid management. The losses from Hypec and CRS, it is first, there might be a blood loss associated with major debulking surgery. There might be an evaporative loss due to an open abdomen. And there might be a perioperative third space loss due to peritoneal inflammation by the installation of the chemotherapy drugs. So for this, we have to monitor the cardiac output. With cardiac, we can do a cardiac output monitoring, pulse pressure variation, and urine output monitoring. Point of care testing is necessary, and fluid replacement can be with crystalloids or colloid or blood. Coming to the hemodynamic management, maintenance of the end organ perfusion is of utmost importance. Increase in body temperature with chemotherapeutic agent, it causes peripheral vascular dilatation. So in response to this, there's an increase in heart rate to maintain the cardiac output. In closed technique, there might be an increase in airway pressures and central venous pressure due to increase in intra-abdominal pressure, which is just similar to the pneumoperitoneum. In coagulation management, hypothermia might always impair the coagulopathy. So, monitoring of INR, PT, and APTT with or point of care testing with TEG and ROTAM might be useful. Temperature monitoring, temperature management during cytoreductive surgery, there is risk of hypothermia because of extensive debulking and also large area of exposure. So, due to this, due to hypothermia per se, there's increased risk of blood loss, risk of surgical wound infection, and hypothermia also alters the pharmacokinetics of our drugs. So, for this, we have to use warmed fluids, forced air warmers, and warming blankets. Whereas uh, in Hypec, there is the solution is heated up to 40 to 43 degrees Celsius. The body temperature might rise to 40.5 degrees Celsius. So because of this hypothermia, it increases the systemic oxygen demand. Also, it increased metabolic demand, and this raises the end-tidal CO2 values, and also there can be concomitant metabolic acidosis. So this puts the patient at risk of coagulopathies and liver dysfunction, neuropathies, and seizures. So during the hypox phase, we should always give cooling blankets, and cold head wraps or cooling blocks can be used to regulate the patient temperature. This coming to the role of regional anesthesia and hypox, it is usually a painful procedure with pain score almost equal to that is associated with that of thoracotomy. The pain is usually controlled with epidural analgesia, and this decreases the use of opioids. Coming to the chemotherapeutic agent, we should always have a knowledge of about the chemotherapeutic agents because cisplatin has been associated with prolongation of QT interval. Mitomycin C and doxorubicin are also associated with myelotoxicity and neurotoxicity. That's it, sir.
Okay. Very good.
Thank you, sir.
It was quite a detailed presentation, but a few points are missing. Where will you play? How do you know the temperature? How will you monitor the temperature of the patient? You said the patient can become hypothermic and patient can become hyperthermic during installation. You have not talked anything about monitoring the temperature.
Temperature monitoring, sir.
Where will you put the temperature probes? How many probes are required? Where all will you place the probe? That is a very, very important monitoring during Hypec surgery, isn't it?
Yes, sir. Yes, sir.
So that is one point that is missing.
Okay.
Then you said you have to have a invasive monitoring. You want to measure the cardiac output, stroke volume variation. So what type of monitor is required for all this invasive monitoring? How will you monitor the cardiac output, stroke volume and stroke volume variations because of the large fluid shifts that is likely to happen? What is the method of monitoring? You are just your NIBP and ECG multiparameter, ordinary multiparameter monitor will be sufficient?
No, sir. CVP, pulmonary artery catheter, and arterial line.
No, what type of special monitor you require for that? You know the name of that?
PITCO cardiac output monitoring.
It's called Vigilo or flow track. Okay,
Flow
it is
track.
called flow track or Vigilo monitor, which measures all these cardiac output, cardiac index, stroke volume variation, stroke volume, okay, all the other
Yes, sir.
global effective ejection fraction, global diastolic end volume. All these parameters are given because it's a large shift. Yeah? And you must include these safety for the personnel in this question answer also. What are all the professional hazards that you will undergo if you are doing Hypec surgery? Both to the operating surgeon, anesthetist, and the theatre personnel. What are all the health hazards they can suffer from? That also has to be included.
Okay, sir. Yes, sir.
But otherwise, your basic concepts you have described very well.
Yes, sir.
And what stage of patients are taken up for this surgery? You know, all cancer patients are staged stage 1, stage 2, stage 3, stage 4. Which stage patients are suitable for Hypec surgery?
But
When will you call a stage 4? What is the tumor TMN classification? Tumor mass nodes.
T4N3.
So this is stage 4 always because all the distal metastasis happen, isn't it? All the peritoneal infiltration means it has come out from the primary source, gone out of the place to spread all over the peritoneal cavity. Okay. So this in earlier stages, surgeons used to do a laparoscopic inspection, and once they find a lot of peritoneal seedlings, they will just come out and say it is inoperable and allow the patient to go for chemo or radiation and just dump them. That's all. But after the advent of this Hypec surgery, as you said, the survival rate has increased because they are first macroscopically removing all the secondary masses by looking at the whatever is visible to the naked eye, and then destroy those cells which are not visible to the naked eye using the chemotherapy at a higher temperature, which is acting locally on the cells. Okay. So that is the way it is working, and it has proved to be a good treatment for survival as well as relieving the patient of all the stage 4 pain. These patients invariably suffer from intractable pain and they require a lot of morphine. Escalating doses of morphine are required. All those things are now not required once you remove all these secondaries, and their quality of life also improves. Okay. So you have done a good job by doing a good presentation, but you have to add